this last video, I will review the 4 types of interviews discussed in Chapter 8. So we have intake interviews, which are often done as the first session before a client starts psychotherapy. We have diagnostic interviews, where the goal is to form an overall conceptualization and provide a diagnosis. We have mental status exams, which are used to see how a client is doing on a particular day. And then we have crisis interviews, which are intended to assess a client's level of risk. So in an intake interview, the main goals are to determine whether a client needs treatment, and if so, what form of treatment is needed. So this is going to involve a lot of detailed questioning about the client's presenting complaint. What this means is essentially what brings the client in and why are they seeking services. So in an intake interview, you're not necessarily getting a comprehensive overview of their history. You're really going to be focusing on what is bothering them in the here and now, getting some general information about their functioning and distress, but you're not necessarily need to get everything about their childhood, for example. And if the client does begin psychotherapy, you will obtain more information over time in your work with them. A diagnostic interview, by contrast, the goal is usually to assign a DSM diagnosis to the client's problems. So this is going to include specific questions that relate to the criteria of DSM disorders. And you're also likely going to obtain a more comprehensive picture of the client's life, because you're going to want to know, when did problems first start? What kinds of other difficulties has the client experienced? So if you're interviewing an adult, you still might be getting asking a lot of questions to understand how school was, how their developmental periods were, to really get like a full picture of how things have progressed for them. But a diagnostic interview can look different. So you can do a structured interview, a semi-structured interview, or an unstructured interview. In a structured interview, an example of this is referred to as the SCID, and it's the structured clinical interview for the DSM. It's fully structured, so you literally kind of have a book that tells you which questions to ask. And the advantages of this is that you can very easily match what the client says to what the DSM says and form a conclusion on whether they meet criteria for the DSM diagnosis. It is also rooted in empirical research. So the SCID was developed based on the DSM criteria and has shown that it can be reliably used across clients. And so because of this, it's very standardized, typically pretty uncomplicated. You're asking a lot of yes and no questions. And yeah, it just kind of generally has this kind of robust research support behind it. It also has some disadvantages. Because it is so rigid, it can inhibit some of the rapport building and prevent the client from explaining or elaborating on their answer. It doesn't really allow for questions that aren't related to the DSM diagnostic categories. So there might be additional information that you want to gather that's not included in the SCID. And it can take quite a long time to administer. So if you're trying to assess for multiple diagnoses, that can take quite a long time. On the other side, we have unstructured interviews. In an unstructured interview, the clinician is going to be kind of improvising, determining questions on the spot to seek relevant information. It's going to look a lot more like a conversation. So what is much more common is to have a semi-structured interview that includes both unstructured and structured segments. And I would say that most interviews in actual clinical practice would be in this category of semi-structured. So you're going to have some conversations with the client about their development, about how things are going in their life. And then you're going to say, okay, now I have some yes and no questions for you, or I have some questionnaires for you to fill out. And so you're going to have both of these components. The third type of interview is the mental status exam. And I've included here a picture of an example of a mental status exam. It includes a lot of observations of the client. So you can see You're looking at their appearance, speech, eye contact, motor activity, affect. You're assessing their mood, their cognition, which can include kind of their orientation to place, person, and time, how their memory or attention are doing, any perceptual abnormalities such as hallucinations. You're assessing for any kind of high-risk thoughts such as suicidality or homicidality. And you're categorizing their behavior, insight, and judgment. So these are often used in medical settings. So if somebody is, for example, in an inpatient program, maybe on a daily basis, a clinician is completing a mental status exam to kind of describe how they appear on that day. They are often also used in addition to other assessment materials. So for example, I sometimes work with a neuropsychologist to do neuropsychological assessments, and we always include a mental status exam alongside the other tests. It's intended to be very brief, very flexible. Oftentimes there isn't really an actual interview component. It's more something that the clinician can fill out after they meet with the client based on their judgment of how the client presented. And it's really, the goal is to just capture the psychological and cognitive processes of an individual right now. So how did they appear during the appointment? Some of the issues is that it can lack standardization. So there are kind of like different questions like organized across different categories. Also different locations might use a different mental status exam. So like a hospital system might have one built into their electronic medical record, but a different office might just use a different one. But usually they include the same broad categories of appearance, behavior, mood, and speech. Lastly, we have crisis interviews. So these are used to assess problems that demand urgent attention. So things like suicide, self-harm, homicide, child abuse, things like that. And so these are not only intended to be an assessment, but to also provide immediate and effective intervention. So you're both gathering information in the moment while also making sure the client is kept safe. So there's almost always an intervention component kind of coupled with the interview. Historically, people used what were called no suicide contracts, where the clinician and the client are kind of just making an agreement that the client won't hurt themselves. And it often involves having the client kind of sign a literal contract saying that they will not harm themselves. These have not been found to work over time. Oftentimes it can kind of send the message that the clinician is more concerned about their own liability, and there isn't really an active intervention part intended to help the client know what to do instead of harming themselves. So a better plan is to do what we call a safety plan. This provides better support for the client. It offers them alternative coping behaviors, people they can turn to, and really just a plan for what to do when thoughts of harming themselves or someone else come back. Some of the key components of a crisis interview are to quickly establish rapport. So it's really important to have the client trust you, but this may be the first time you're meeting with the client. And so jumping straight into interviewing is not recommended. It's important to kind of quickly establish some rapport and show the client that you're really there for them, as well as expressing empathy. So you don't want this to be a punitive process. The client is not in trouble. They're rather expressing that they are experiencing a lot of pain, and it's really helpful for the clinician to be able to express empathy towards that pain. So some questions that might be included in a crisis interview. It's good to assess how depressed, distressed, or hopeless the client is feeling in the moment, whether or not they have suicidal thoughts, if the client is able to think rationally, especially in a problem-solving way. And this one is particularly interesting based on kind of theories of suicide that really have found that suicide is a product of the inability to think in more creative ways. And so when someone is feeling really, really intense levels of distress, sometimes death feels like the only option. But if the client is able to think rationally and kind of in a problem-solving way, then you can help them come up with alternative plans versus having suicide feel like the only option to them. It's helpful to assess whether the client feels disconnected from other people or like they're a burden to other people, because an important part of a safety plan is identifying other people that the client can call or be with. It's also important to assess whether the client has a specific plan to harm themselves. So having thoughts about wanting to be dead versus having an actual plan to kill themselves, it's really important to distinguish there because the level of risk can be different. It's also helpful to know if the client has self-control in the moment. This can include things like if they've been using any substances, as well as their kind of level of impulsivity in the past. And then really just understanding how definite their intentions are. And this will likely inform the next steps. So the next steps might include forming a safety plan with the client. And so this helps the client identify kind of their own warning signs and triggers, their own ideas for coping strategies, so what they can do to keep their mind off of their problems, places and people that they can turn to when they're feeling this way, as well as specific people who can help them when they don't feel safe. And this might include also calling a service such as the crisis intervention team. If somebody is at very high risk, then hospitalization might be the intervention that's needed. But sometimes having a safety plan where friends and family are involved are sufficient instead of going to the hospital. And that is often a judgment call that a clinical psychologist has to make. It is important that for all clients that you do a crisis interview with, that you stay with them until there is an adequate safety plan in place, whether that is a warm handoff to kind of a higher level of care, such as the crisis intervention team or a hospital, or if you've created a safety plan with them where you feel confident that they will be kept safe. And this is really going to vary from client to client and situation to situation. And when you go get more training to be a psychotherapist, you get a lot more training in this area. So that is it for chapters 7 and 8. If you have any questions, please add comments on perusal or send me an email. We've covered a lot in these 2 chapters, but I think it's a helpful way to kind of understand how broad assessment can be in clinical psychology.